Now may I invite Dr. Siddhartha Mani.
Good afternoon, sir. Thank you, respected chairpersons, my co-speakers, and my sincere thanks to Dr. Shantanu sir for inviting me in this warm-up debate. So while I share my screen, my colleague has very wisely coined HBPM and HBPM as complementary rather than bringing in a competition between the two. And he has spent only one slide in establishing HBPM superiority over HBPM. That is helpful for me. So, and my dissent role is to establish HBPM as good enough. I need not establish the superiority of HBPM. We already know the huge burden of hypertension over Southeast Asian countries. We know that it is underdiagnosed and undertreated, and it adds a lot to the burden of cardiovascular disease, being one of the most powerful modifiable risk factors. So there is a big list of do's and don'ts in the BP measurement, and I believe that most of you go meticulously about these measuring steps. But my sincere apologies that in busy schedule, I personally probably do not stick to all these BP measurement parameters which needs to be checked before checking blood pressure in my patient. So I believe that there are a lot of drawbacks in the office BP measurement, and there is many scope of error and bias. So that is why we came to know about the entities like white coat hypertension, like mast hypertension, and there we felt the need of out of the office BP measurements. Now, this ambulatory blood pressure monitoring was no doubt a very interesting and important tool which the BP of the patient at different activities, at different times of the day, at different levels of emotional activities, physical activities, and accordingly every 15 minutes or 30 minutes they keep on measuring the blood pressure and gives us a recording, a graph over the 24 hours. But obviously there are certain doubts about HBPM. The very practical doubts which comes to the mind of the clinician and the patient at the very beginning is the availability in the primary care setting, particularly the cost, the patient discomfort, whether it is disturbing work or sleep of the patient, and whether there can be loss or error in the data due to technical issues. Then we came to know about a very interesting thing, that is the home blood pressure monitoring, which is just measuring the blood pressure of the patient by patient himself or herself, or the person who is looking after the patient, which is done at the home just twice a day, 2 readings a day. And at each time, there has to be 2 separate readings taken at 1 minute interval. The first reading should be taken in the morning within 1 hour of waking, after urination and before breakfast and drug intake. And the second reading or the last reading should be taken at the evening before going to bed. And this has to be done. Different bodies, different countries, they recommend different number of measurements, but overall it is followed that at least 3 or 4 measurements has to be taken, preferably or ideally 7, that is for 7 days. Some bodies, some countries, they ask for discarding the first day measurement and do an average of the last few days measurement, or sometimes we consider all of them. So this is just a 7-day period of measuring the blood pressure twice a day. And if we ask our patients to follow some basic instructions, I think that they follow it more meticulously than we do in our busy OPDs. So before going into the argument any further, let us see the verdict. For a clinician, the verdict, the ultimate verdict is given by the patients. And this is a clear-cut data from the patients regarding the patient preference for ambulatory or home blood pressure monitoring, which shows that 82% patients reports a positive overall opinion for HBPM compared to 63% for HBPM. And among the patient population, 60% chose HBPM for their next BP evaluation. There has been moderate to severe discomfort for using HBPM reported by 55% of the patients, and severe restriction of their daily activities by 30%, which is compared to 13 and 7% only for HBPM, and the result is quite significantly different. So what is this home blood pressure monitoring? Measuring the BP by automated oscillometric device. And this is used to give improved diagnostic accuracy. This is an out-of-office BP measurement structure which can strongly predict the cardiovascular outcomes like coronary artery disease, stroke, or even mortality. And it has been reflected that every 10 millimeter increase in home blood pressure monitoring, that causes an increase of the hazard ratio by 1.17 to 1.23 in most of the studies, and even further in some meta-analysis. What are the indications of HBPM? Any patient with hypertension, rule out white coat or masked hypertension, evaluation of resistant hypertension, evaluation of the medication-related hypotensive symptoms. This is very important because many of our patients, they come to us and they blame our medicine that after taking this medicine, I am having giddiness, I am having tendency of blackout, I am having tendency to fall. And they try to stop this medication or convince us that yes, this is being caused by the medicine. And their HBPM can very accurately tell us, or even tell patient that say, after taking the medication, your BP is not falling, and this is not due to the hypotensive symptom. We can evaluate the midterm day-by-day BP variability. We can evaluate the seasonal variability, because as my colleague was saying about the nocturnal and daytime BP variability, there also is a prediction that summer versus winter BP variability, they can also predict the CV mortality. More the variability, or if there is an inverse relation like BP increasing during summer and decreasing during winter, these patients, they show even more CV events. So these are certain things which can be very easily monitored by HBPM, and ABPM, with ABPM it is not possible. An improvement of patient's adherence to treatment, obviously, if the patient can measure his BP every day, there is beautiful adherence to his treatment and BP follow-up. So what are the advantages of HBPM? We can take multiple readings over an extended period of time, not even for 7 days. The patient can do it every day if he wants. We can avoid white coat effect. It is reproducible. It is predicting CV mortality and morbidity much better than office blood pressure. And it can diagnose white coat and masked hypertension. It helps the patient to better understand the management. Tele-monitoring is possible. The patient can report to the clinician about his BP variability in a very short time, and as I said, to detect the BP variability. Obviously, it is not all good about my child. It also has some disadvantages, like there may be some inaccuracy in the measurement procedure, cuff placement. There may be some inaccuracies, technical errors in the devices. There is lack of nocturnal recording because during sleep patient cannot measure. So obviously there are certain limitations, but overall this helps, this engages the patient in his blood pressure management to a much greater extent than ABPM does. It increases the clinician confidence also in the blood pressure recordings and measurement, because we can follow up his blood pressure day by day. And the lifestyle changes, the lifestyle adherences, everything improves, and that gives better control of the out-of-office BP. So now we have to look about the accuracy. If you look about the accuracy of the measurement of this home blood pressure, you can see that although there are some divergences of the measurements, most of the measurements club towards the normal office BP line. So there is less chance of accuracy. And if you compare ambulatory versus home in different substrates or stratum, you can see that detection of white coat or masked hypertension, both ambulatory and home, appears similar in efficacy. Assessment of the nighttime BP or the early morning surge is something where ABPM scores a little bit over HBPM, because during sleep it can measure the BP as well. But I have a concern that if every 13 minutes the cuff gets inflated in ABPM, that may disturb the patient's sleep as well. And we do not exactly know that every time if the sleep breaks, how much that increases or that affects the BP monitoring in the patient. The other parameters like measurement of the morning hypertension, effect of the antihypertensive drugs, improving patient's compliance, patient's control rate, I think, and data also shows that HBPM is scoring over ambulatory blood pressure monitoring. And obviously there is more availability, less cost, and more reproducibility of the HBPM data. And accordingly, seeing all these good effects of HBPM, 2017 hypertension practice guidelines, they considered self-measurement BP, that is HBPM, to be a more practical approach than ABPM, particularly for patients taking antihypertensive medications. And I will not go into the details of the guidelines, but wherever the standard guidelines has mentioned ABPM, they have equally mentioned HBPM. They have never given an age, given ABPM an age over HBPM. Everywhere it was mentioned for a mask hypertension, white coat hypertension, everywhere that either HBPM or ABPM should be followed. So it is not one over the other. There is good corresponding values. We know, we are sure about the corresponding values of the office BP and how much that will correspond to the home blood pressure monitoring. So there is also no doubt regarding what should be the home blood pressure measurement. Accordingly, we have set our diagnostic thresholds. Mostly it is more than 135 by 85. We have set our cutoffs, the target BP levels, and everything is very specific and well defined with HBPM. There has been a lot many studies with HBPM, and each of these studies show that the hazard ratio of CV events, mortality, hospitalizations, that is being well reflected by the HBPM monitoring. Every one standard deviation of the HBPM is giving 1.2, 1.3 hazard ratio for the CV events. So there should not be any doubt that HBPM do not reflect properly the hazard of cardiovascular events. It properly and efficiently reflects. And if you compare home versus office BP, you can see these meta-analysis also, they showed that hazard ratio is quite comparably increased by HBPM and office blood pressure monitoring. So there are even recent devices which uses thermosensitive monitoring for hypertension in the home blood pressure setting, home blood pressure monitoring setting. So there are improved techniques, improved machines coming up, which will give more accurate blood pressure. And if you look at the association between home blood pressure and stroke risk, in the JHOP study also, the home blood pressure monitoring was very efficiently reflecting the increased stroke risk. This is a very interesting slide. If in the upper panel, you can see that the patients were measured by ABPM and the patients defined as nocturnal hypertensive and nocturnal normotensive. The CV risk, the CAD or the stroke risk was measured. And same thing was done with HBPM. So HBPM defined nocturnal hypertensive versus HBPM defined nocturnal normotensive. You see the curves are diverging more with HBPM. That means HBPM is more efficiently reflecting the increased hazard risk for CV disease, coronary disease, or stroke in the nocturnal hypertensive. So the justification of measuring nocturnal hypertension better with ABPM falls with this data. The risk of stroke, if you calculate the multiple risk factor classification also, there also the home blood pressure is very efficiently reflecting the increased risk of stroke or the increased hazard ratios for MACE, major cardiac events, with home blood pressure monitoring only. If you look at the mast hypertensives and if you stratify them in mast hypertension patients with optimal office BP, with high office BP, with normal office BP, in all these subgroups, again, HBPM is efficiently reflecting the increased hazard ratio and it is comparable to the office blood pressure measurements. So just I mean to stress that office blood pressure measurement and home blood pressure measurements, they are giving exactly similar picture in identifying the risk of stroke.
Dr. Mani, please wind up.
Yeah, I just finished, sir. So if you compare now the diagnostic accuracy of home versus ambulatory blood pressure monitoring, you can see the sensitivity, the comparability, the agreement. You look at the agreement column, it is more than 85% agreement in all the different stratum between ABPM and HBPM. And recent study that showed surprisingly that HBPM demonstrated better reliability or the best reliability and strongest association with LV mass index, which is an important predictor. So HBPM not only provides a predictive measurement of BP, but also offers the opportunity to move hypertension management out of the doctor's office, thereby empowering patients for a greater role in self-managing their health. So thank you so much.
Thank you, Dr. Mani. Both the speakers have done very well. Basically, it is a debate. So it goes to who can prove his worth better, which speaker did better. So I think there is a chat box. If the participants like, they can vote for either Dr. Mani or Dr. Somnath. Overall, just to summarize, I'll take 2 minutes because the time has been already crossed, but we started 4 minutes late. That's why if we think about the vastness of our population, and so many people remain undetected, perhaps both the methods are not suitable for the remote parts of the and poorer community of the country. But even if we have to compare between the two methods, they are basically complementary. Majority of the things, as Dr. Mani showed, could be done by the HBPM, but at times, particularly to show the evidence of nocturnal dip, over dip, under dip, etc., ABPM may be necessary, or tendency to fall while awaking from the sleep due to hypotension caused by chronotherapy or some other problem may be revealed by ABPM better. So these are basically complementary. So for day-to-day basis and for better monitoring, we can do with HBPM. In fact, in my practice, I do it. Now, in certain cases, additional 24-hour ABPM may be necessary. Perhaps when the better, smarter devices come out, which can do both 24 hours monitoring as well as long-term monitoring, like the wristband or something, and when they are standardized, validated, without flaws, with epidemiological basis, perhaps they will be the answer. So if Dr. Rai has to say something, he can say. There is no time for rebuttal or battle. So that's why I just hand over to Dr. Rai for his final comments. You can put your votes in the chat box. Nobody has done it. Yes, Dr. Rai, please.
Thank you, Arup. Just a comment that I reiterate with Dr. Mani that this procedure, the ABPM, is pretty uncomfortable, and the patient has, a lot of patients have told me that, it was, quite every half an hour it gets inflated, and it does affect the sleep rhythm. So how does it affect the nocturnal blood pressure? I really do not know that thing we need to be. But otherwise, both are complementary to each other, and obviously for the ease of measuring the blood pressure, I think ABPM in this part of the world has got an edge over the ambulatory blood pressure disease. So with this note, Arup, can we just conclude this session?
I think, yes, you can.
Both the speakers for your excellent.
Both have done very well. So just give them the compliments and wind up.
Thank you both the chairpersons and both the speakers, the debaters rather. It was a fantastic debate, definitely. But both are very mild people, not so aggressive to fight.
So it didn't seem a debate. It seemed a presentation, you say.
Yeah.